GARFIELD is a very interesting project. It is basically a large real-world outcomes registry. We're going to follow 55,000 patients prospectively to try and understand what is the burden of the disease of atrial fibrillation, what happens to these patients over time when they're followed for many years, what are the kinds of outcomes that they're experiencing, how are we using anticoagulants to prevent stroke, and how can we do better. And so the purpose of today's symposium was really to try and communicate some of the fascinating insights that are starting to emerge from the GARFIELD Registry now that we have some 24,000 patients included.
We now have 2 cohorts available, the data on anticoagulation or antithrombotic administration. And the bottom line is that still nowadays we are not doing very well in providing adequate antithrombotic therapy.
I do find it very depressing that given the robust evidence base from randomised controlled trials of the effectiveness of anticoagulation in stroke prevention in atrial fibrillation, that we are still using it inappropriately, and we are still using anticoagulation inappropriately for those patients at low risk and under-treating those patients at high risk, and yes, I do find that depressing.
So we have to step back and ask ourselves, how can we make a paradigm shift? How can we change this unacceptable situation? And one idea we have is to apply the same methodology that we use successfully to get venous thromboembolism prophylaxis successfully employed in acute care hospitals across the world. And we used various techniques. One of them was educating clinicians. Another was educating the public. So the public, when they became hospitalized, would say, "What, doctor, are you doing to prevent my pulmonary embolism or deep vein thrombosis?" And it's quite possible, if we use a variety of tools and techniques learned through the venous thromboembolism prophylaxis story, applying it to stroke prevention and atrial fibrillation, we might be able to make great strides forward.
We wanna continue warfarin, but in some reason we have to stop warfarin. Probably in some patients it is very difficult for controlling INR. And the clear message demonstrated by GARFIELD is, if warfarin is not well accepted by the patient, that patient has a bad outcome. So warfarin is good for selected population of the patient, but not in generally patients. So we need more.
Registries actually don't only answer questions. Part of the real importance of the methodology of a registry is to be hypothesis generating, to raise questions that will be answered in different types of clinical trials in the future. So I'm very satisfied that we're raising a lot of questions, as well as providing insights and answers into many of the issues that face clinicians in real-world everyday practice.